Hi guys, Dave Man Max 6, and this is Ask the Doc, the first one of 2015. Dr. Rand, how are you?
Fantastic. Happy New Year.
Happy New Year to you. We actually skipped a week because you were on vacation back home in Florida, so this is actually the return to the show, first show of number 3 out of what we've done so far. So you had a good time in family and everything? It was good?
Had a great time.
All right.
Coconut Grove, that's my old stomping ground.
Yeah, you had fun with all your buddies. You have the entourage crew you're telling me about. That's awesome. All right, so back to business, you guys. I got some great questions for Dr. Rand this week. First one, we're going to start right off the bat, is what would be the dosage of testosterone used by a national or IFBB pro level competitor that you've heard of in your career?
I've seen guys, and of course, I can't supply any of these things to anybody. I can only deal with hormone replacement therapy, but of course I get a history, and I've seen some pretty high doses, but I've seen some pretty, what would be considered nowadays, relatively low dosages doing the same deal.
You mean same results?
Oh yeah. I mean,
okay.
I probably have the privilege of seeing about a half a dozen of the top 15 Olympia contenders.
Wow.
And there are some of those that I've talked down to as little as 600 milligrams of testosterone, for example, per week.
Okay.
And then you have guys that are doing closer to 2.5 grams per week. I don't have anybody who does more than that I'm aware of. I'm assuming that they're telling me what they are doing.
Yeah.
And again, my job is just to guide them, help keep them out of trouble, and do the best they can with it. But I've heard stories, but that's just stories. But,
yeah.
I mean, to the point about being able to do well with it, there are some studies that show that in actuality, up to 600 milligrams of testosterone per week can be more healthy for you. Now, you're not going to see that accepted by the AMA anytime soon, and it's definitely not standard of care.
Right.
For hormone replacement therapy, we usually use about 1 cc, 200 milligrams per ml of testosterone cypionate per week.
Right.
And we're not talking about a whole lot of studies because that's not what we do here in the U.S.
Right.
But I'm not talking about the Hungarian Journal of Bad Science. No disrespect to Hungary, but just, these are some real studies. I think there are at least 2 or 3 that I can think of right now that show, other than the usual things we have to be suspicious for, which is elevated hemoglobin and hematocrit, always watching out for elevated estrogen levels. There are no signs and symptoms that we have to worry about. Actually, people get bigger, stronger, faster, healthier, feel better, etc. So I hope that answers the question.
Yeah, that's good. That's a good range. So you said between 600 to 2,500 is what you've seen personally.
I've seen it, and the problem with that is the whole thing about receptors.
Yeah.
I mean, how many receptors do you have?
Yeah.
You're definitely down-regulating receptors, and how many can you activate it even when you've down-regulated the receptors as far as you can.
Right.
Really, what you're dealing with after a certain point, anyway, is you're going to have to use drugs for the drugs,
right,
because the drugs convert. Obviously,
right,
testosterone into estrogen and/or dihydrotestosterone, and it's just not the smart way to do it.
Yeah, that's a good answer. Thank you. Okay, this one's actually is for a woman, which is first time for us. So, could a high level of testosterone cause acne and facial hair on a woman in her mid to late 20s? If so, what can she be prescribed, and are there any side effects to correct that?
Absolutely, but to be specific, it's typically not the testosterone that's causing the problem. It's what testosterone gets turned into. Dihydrotestosterone that causes acne. That's why you'll hear stories of educated dermatologists prescribing spironolactone for women, because one of the side effects, and for some reason it only works with women, probably because the testosterone levels are much smaller than with men, but with spironolactone, one of the side effects other than diuresis is a blockage of the conversion from testosterone into dihydrotestosterone via 5-alpha reductase in the liver. So up to 100 milligrams of spironolactone can be used. And of course, women love it oftentimes because they like to get rid of the extra water weight as well as get rid of the acne. But the problem is not per se the testosterone. And I'm not sure if she's referring to just having a naturally high level of testosterone, and that can be related to polycystic ovary syndrome or what they call it, metabolic X syndrome, and those two are tied. But it's definitely not because of testosterone directly. It's from what testosterone gets turned into. And either way, an excess, whether it's through a predisposition genetically or through supplementation, excess testosterone will convert to dihydrotestosterone and cause a problem. I like to use finasteride because I deal with a lot of athletes, and just in general, it's not a good idea to be dehydrated. So you can use finasteride. You can find an appropriate dose which will reduce the acne. And all finasteride does, its sole job is to, as a 5-alpha reductase inhibitor, is to stop that conversion. So,
so males who, because a lot of times males will tell you, or will tell me, oh, I get a lot of acne. That's a good way for them to go.
Yeah, first line of defense is to use finasteride. You can start with 1 milligram, go to 5 milligrams. You can even go to 10 milligrams. But there's another substance, dutasteride, a little more expensive, a different base, but much stronger than finasteride. I think it's, and I get this backwards all the time, 100 times more strong and 300 times more strong on the skin and on the prostate. And I don't know, again, which is which off the top of my head, than finasteride. So that one's kind of like pulling out the bazooka,
right?
You're just going to blow everything up, so to speak. Wow, and that works a little bit better.
Nice, thank you. As I'm reading the next question, it's kind of like interesting because you just sort of answer it with number 2. But when you are in a cycle for say 10 to 12 weeks and then you stop, why is it that some people develop severe acne on their chest and back, and what can be done about it? Why does this happen, and how do you prevent it?
When you say using a cycle, then my assumption is that it's not a hormone replacement therapy patient. It's someone who's bodybuilding or doing something, and
who knows what they're doing.
Well, you're talking about cycling. I mean, what's the purpose of cycling? The purpose of cycling is to preserve testicular function. So the only people that cycle are people that, presumably don't need hormone replacement therapy. So with that assumption in mind, what I would presume is happening without knowing per the labs is that when you stop your cycle, your body is going to rebound and produce a lot more testosterone than it was before, certainly while you were on the cycle.
Yeah.
During which time the natural testosterone production is reduced.
Right.
And that can happen. It does happen. And so my assumption is that if this person is experiencing more acne after the cycle stop, that they're just in a phase of rebound, and that should go away, level off. A lot of guys use HCG for what is termed post-cycle therapy to try and minimize that swing by either during the cycle to keep the testicular function going throughout, or to minimize the rebound because they're already starting to increase the endogenous production before they absolutely go cold turkey. The other thing I want to add there is a lot of people think that post-cycle therapy, smoothing that transition using HCG, is done with 3 weeks right after your last injection of testosterone or whatever you're using, and that's not the case, and that might be amplifying the rebound because you've still got so much testosterone in your system. And again, depending on if you're using, again, I'm not assuming a replacement dose. This is probably somebody who's doing a cycle 600 milligrams or 2.5 grams or whatever we talked about earlier. So even though the half-life, which by the way is a rate, just a reminder, not a time period, of say testosterone cypionates 8 days, terminal half-life would be 40 days later. But if your levels are sky high, 3 weeks later, I've seen it. Guys are still off the charts. LabCorp doesn't measure above 1,500 total serum testosterone, and they're still there 3 weeks later. So you're still using HCG just to remind your testicles not to go into senescence, if you will, the Leydig cells. So you're still, my point is, you're still going to find that drop-off point if all you're doing is HCG for that 3 weeks after your last injection at high dose steroids or testosterone. I hope that makes sense.
Do you feel that HCG is something that you should keep doing throughout the cycle? Do you think it would be better to do it during HRT or the cycle, just like you said Arimidex should be given as well, for different reasons?
Well, Arimidex should be there all the time,
yeah,
because testosterone obviously converts to estrogen,
right,
and estrogen is not our friend when it's inside of us, except for a little bit.
Right.
We should have enough for brain health, cardiovascular health, and joint health. But beyond that, we want to minimize it. So
right,
you're increasing your testosterone levels, you got to avoid the increase in estrogen,
right,
therefore. But with HCG, the reason I use it in hormone replacement therapy is there are guys with low testosterone that still want to have children or haven't had enough children yet. And it helps preserve testicular function, specifically Leydig cell function, so that possibly they can still conceive while on therapy.
I see.
Or if not, when they decide, okay, I'm going to go for it, it's not so hard to get them fertile again if they've lost fertility.
So is that the only reason why you would keep them on during? If not, you just do it towards the end?
The only other reason would be for cosmetic reasons, because
oh, yeah, you told me.
Testicular shrinkage. I
right.
mean, the atrophy that occurs, I believe the Leydig cells make up roughly 20% of the testicle, and that's a significant amount of shrinkage if those, because they're not being called upon for any reason anymore, because you're supplying exogenous testosterone, they shrink down, senesce. It'll cause shrinkage.
Yeah, yeah. Gotcha. All right, thanks, Doc. Okay, question number 4. Have you ever seen any of your patients develop what is known as nail clubbing as a result of using these types of compound over a long-term period of time?
No, because nail clubbing generally occurs as a result of continued chronic oxygen deprivation. If it's true, nail clubbing, the term we use is for that. Although I have seen one patient who had the look of nail clubbing, but it was congenital. He's always had that look. So no, I can't think of a mechanism of using testosterone that would reduce your oxygen levels chronically so that you'd get nail clubbing. That's seen in something like a patient that has emphysema.
I see.
Okay? That's how severe we're talking.
Okay, cool. Okay, next question. Why is it that stacking Tren and Masteron give you a bad cough as soon as you take the shot? Why are you laughing?
Well, it's just the subject matter, I guess. Well, I can't say for sure, but if we're talking about trenbolone,
yes,
or Masteron, this is an injectable Masteron, which I haven't heard of, but probably exists out there because they do just about anything. But trenbolone is obviously going to be illegal, bootleg, made in somebody's garage or something. So what I would assume is happening is that someone is using the proverbial baker's dozen of benzyl alcohol to help hold the trenbolone in solution, whether it's acetate, which is typically what's seen, or I think it's a little more difficult to make a nanthate. But the reaction, which is referred to as the tren cough.
Yes.
Which again, if this person is using both those drugs, probably it's attributed to trenbolone and would have nothing to do with Masteron, but possibly with Masteron also. Anytime these underground suppliers are making the drugs, they're using more benzyl alcohol typically, I imagine, than they should, because they're not sure. I mean, garages probably are not made complete with a sterile hood,
right?
But to make sure that it's not only mixed, but there isn't going to be a problem with sterility, they're throwing this extra benzyl alcohol, And that's what I think is coming up through the lungs. You might hit a vein, and probably the cough is occurring within like 60 seconds or less.
Yeah.
And probably lasts for about 5 minutes or so. And
so it's not dangerous. It's not like...
I can't see why it would be dangerous. It's probably very uncomfortable. You're exuding alcohol through the lungs, and alcohol in any tissue doesn't feel good. So, these questions are difficult because I'd have to ask specifically if they know more about it. Yeah, I got this from my garage salesman down the street, and he makes a batch that has 4% benzyl alcohol instead of 2%.
Oh, I'm telling you,
that would lead us to believe that that's probably what's going on. But I can't think of any other reason why any of those drugs would cause a cough.
Okay, so it's not the actual active ingredient itself.
It's the excipient. It's what they use to hold it in solution and also preserve sterility.
Gotcha. Okay, thank you. All right, Doc, last question for today is actually a good one. What are your views on HMG uses in males? There's tons of info on HCG, not so much on HMG. My friend, a past user, has been trying for kids for over a year now, and his LH and FSH are just not coming back. So it's obviously a question about fertility, right?
Yeah. Well, HMG, human menopausal gonadotropin, is used for fertility purposes. Obviously, that's to what he's referring. A year is a long time to not get your fertility back. So the first thing I would wonder is your friend actually being abstinent from any sort of hormone replacement therapy? Because the easiest way to restore your fertility is actually, I say easiest, most efficient, is going cold turkey. It is definitely not the easiest. But when your body realizes that you've got almost no testosterone, your pituitary will kick into overdrive to send a stimulus to the testicles to start producing again. The problem is the Leydig cells, which we were talking about earlier, they have decided that they can take a nap because they're not needed anymore, depending on how long someone's been using replacement therapy or steroids. And it's really not the dose that's the issue. It's the chronicity of use. If someone's been on for a long time, it's going to take longer to come back typically. Add to that age. The older you are, the harder it is for you to snap back, and you might have a long time before you become fertile again. One of the other issues is it's not just about getting the signal. Well, no, it is about getting the signal to the testicles going again, but it's not just about testosterone. You also have to worry about conversion. The liver has gotten used to high doses of testosterone, and the body likes ratios, so it's gotten very efficient at converting testosterone into estrogen. So you may start coming back online a little bit, meaning producing more testosterone, but your body's converting it into estrogen. If your brain recognizes that either your estrogen or your testosterone is sufficient or even high, particularly with estrogen I'm referring to, it's not going to send a signal. In other words, you can have low testosterone but high estrogen, and your pituitary is not going to send a signal to testicles through LH, luteinizing hormone, to produce more. Okay?
That's a double whammy.
Right. So you got to do both. So what my point is, when you're trying to become fertile again, it's not just about stimulating Leydig cells. It's also about maintaining an adequately low level of estrogen so you can get your body to do it on its own.
There you go.
But the issue beyond that is the sperm cell has to have localized testosterone to germinate. In other words, the Sertoli cells are usually working just fine because you haven't stymied their production directly. You have by stifling the production of testosterone because you're supplying it from without. If you could somehow get the Sertoli cells to start, get an early stage sperm, systemic testosterone will do the trick for the rest of the cycle of the sperm cell, which is usually 74 to 76 days. So HCG or getting the body to produce LH is usually enough to get things going again. But going back to this gentleman, if he's sneaking in, just 50 or 100 milligrams of testosterone cypionate after already having shut down his system before, he may be sabotaging the project. And if the Leydig cells don't ever come back online again or enough, the Sertoli cells can't get the sperm started. Again, after that, boom. And you have people who get started on replacement therapy and within 3 months have a child. How could that have happened? It's because you already had those sperm maturing, and then, the exogenous testosterone will fuel them. So back to the question, with HMG, if in this case it was determined that no FSH was produced either, there may be a pituitary problem, a central problem with fertility rather than a testicular problem. So HMG, which stimulates the Sertoli cells, would be appropriate, and that's used normally for women, but also for guys that are having a hard time getting fertile. If the production of testosterone is up but no sperm are being produced, you'd have to look into the Sertoli cells being dysfunctional, and HMG would be a good tool, first tool, to see if we can get that changed, and then it would also be diagnostic for that reason. Hope I'm not being too technical, but I just want to explain what's going on. HMG is used to stimulate the Sertoli cells to create more baby sperm, if you will.
Gotcha. Very cool, very cool. Doc, thank you for having us again this week. People are really excited about the show, so am I, and then I hope you want to keep doing it because the questions are just pouring in. So,
Well, my pleasure as always.
Thank you, Doc.
Thank you.